So we have a post-op patient that just had her gallbladder removed. Before the surgery, we did go down and educate her on how to use the incentive spirometer and why we're using it, just so that she has knowledge of it. So after surgery, she has more of an idea. Before entering the room, we're just going to go through and check the patient's chart, look for the pain medication schedule that could alter the therapy results, chest x-rays, previous vital signs, just a basic knowledge. So we'll knock. Hello, I'm Abby from Respiratory Therapy. I'm here to perform some incentive spirometer therapy. This just helps prevent atelectasis and from pneumonia happening, since we're not up and active as we were before. Can I get a name and date of birth, please? Thank you. We're going to do pre-assessment vitals, check for breath and lung sounds, SpO2, respiratory rate, pulse. Then we will instruct the patient that to kind of sit upright. So either we can have, if the bed is movable, we're able to put the bed in upright position, or if the patient is not in that much pain, that they're able to swing their legs over and sit on the edge of the bed, or if they're already sitting in their wheelchair, that would work wonderful. Since she did just have a gallbladder removed, we're going to apply some splinting, so that may include a pillow just being placed over the area. We have a 5'2", 65-year-old patient, female, so we're able to use our chart, 5'2", 65, so 1850. So on the bottom here, we were able to put predicted values. Once we're doing the therapy, we want to reach at least 1/3 of that and work our way up. We're able to add the patient's name, the date, their room number. So once we have them all situated, we'll be measuring for inspiratory capacity, their volumes. We will have the patient hold this on a level position, and we'll have them exhale normally and take a nice slow, a nice deep breath inhale. And once they get it as high as they can, we're going to try to have them hold that for 3 to 5 seconds. We want to do that about 6 to 10 times per hour. So if we're monitoring them and they're performing this very correctly and very accurately, we're able to just allow the patient to do it on their own times. But let's say they're kind of confused about it. In the next hour, we can come in and help perform the next to 10 breaths. After we've completed the therapy, we can reassess the patient, check vital signs, breath and lung sounds, if their respiratory rates went down or up. Then we would want to position them back in bed in a comfortable position. So then we'll just, before leaving the room, we'll make sure that this is in their reach, let's say on a bedside table. If they were able to do the therapy on their own, we'll just kind of re-educate them on taking a deep breath in, holding that, and making sure to let a full breath so that we're not breathing too fast and hyperventilating. So once they understand, we can ask if they need anything, call lights, this is in reach. Then we can say we'll come back in a few hours or whatever the next therapy may be if they need any help. Then I will wrap up with charting.